Queridos amigos y colegas, nuevamente nos volvemos a encontrar en este espacio, que es espacio de todos, la SONECOM, el cual ha crecido gracias al apoyo de todos ustedes. Hoy es un día diferente. Hoy no vamos a poder estrechar nuestras manos, tampoco vamos a poder abrazarnos. El mundo entero cruza por una gran batalla. Tenemos retos muy importantes enfrente y nos han sacado de nuestra zona de confort. Pero nos volveremos a reencontrar y volveremos a ser los mismos de siempre. Quiero dedicar todo nuestro respeto y cariño para las familias de nuestros hermanos médicos y personal de salud que ya no nos van a poder acompañar nunca más. Ellos dieron todo su conocimiento y entrega en pro de la vida. Sé que todos están ahora luchando por ayudar a nuestra gente, que han dejado de lado su propio bienestar para brindarles a otros la oportunidad de seguir viviendo. Y eso se llama entereza, eso se llama profesionalismo, valor, entrega, empatía, vocación, compasión y muchas otras cualidades que tiene el gremio médico. Todos han entrado de lleno a la lucha con el mayor entusiasmo, porque no siempre podemos elegir la música que la vida nos toca, pero sí podemos elegir cómo la bailamos. Hoy nos reuniremos vía remota, continuaremos con nuestro arduo proceso de actualización, pese a todos los obstáculos que tenemos enfrente, porque el gremio médico y el gremio de la salud es un gremio de lucha constante. Para este evento hemos programado temas de actualidad que serán impartidos por profesores de talla mundial. Esperamos que les sean de utilidad. Quiero hacer aquí un paréntesis para dar un sincero agradecimiento a la mesa directiva actual y a los comités que la conforman. Gracias a su incansable ayuda y entusiasmo, se pudieron cristalizar proyectos importantes para la sociedad y que nos colocan un peldaño arriba, como es la revista SIU, Cardiac Imaging Update. Esta revista es una revista en inglés que se publica trimestralmente y que publica artículos de investigación relacionados a la imagen cardíaca. Es una revista Open Access y actualmente está en el número 5. También se inició en esta gestión el simulador Ecoestrés ACLS, en donde los participantes pudieron actualizarse en Ecoestrés, además de renovar su vigencia y sus habilidades en la reanimación cardiopulmonar. A raíz de este evento, también se generó el manual de Ecoestrés ACLS para apoyar a los especialistas en imagen en todo lo que se relaciona y todo lo que tienen que saber del ecoestrés. Esto para poder hacer estudios con mayor seguridad. Este manual estará próximamente a la venta y podrá ser adquirido por todos y formará parte integral de la formación de los futuros eventos Ecoestrés ACLS. Por otro lado, la sociedad cuenta con sus ya reconocidos eventos y tradicionales, como es el evento de las cumbres de casos clínicos, que se realiza cada inicio de año y que reúne tanto a los profesores como a los alumnos y que es el sitio en donde le damos la bienvenida a nuestros nuevos integrantes de la gran familia de la imagen cardíaca. También saben de nuestro magno evento anual, el cual este año quedó pospuesto por razones obvias, pero el siguiente año los estaremos esperando con los brazos abiertos. Tenemos programado para ustedes un evento muy grande, muy importante, que incluirá a toda América, de norte a sur, pero además se han incluido más sorpresas. Reserven por favor las fechas para el 15, 16 y 17 de julio del 2021. Nos estaremos esperando y festejaremos finalmente el gran triunfo de volvernos a encontrar. Quiero agradecer a la industria que siempre nos ha ayudado para poder llevar a cabo este tipo de eventos. Muchas gracias. Bueno, sin más que agregar, reciban un abrazo de todos los integrantes de la mesa directiva 2019-2021 y el mío propio con gran afecto. A partir de este momento, declaro inaugurado los eventos de SONECOM 2020. Muchas gracias a todos.
Buenos días a todos. Es un honor estar aquí con ustedes. Tenemos 329 médicos, personas de salud interesados de diferentes áreas estando aquí con nosotros. Acabamos de tener el honor de oír a nuestra presidente. A nombre de SONECOM, a nombre de ella, muchas gracias a todos los ponentes que están aquí. Hoy vamos a tener 4 módulos. Es muy importante que una vez que acabe este módulo, nos salgamos y entremos con la liga del nuevo módulo. Es muy importante que tengamos las preguntas que queramos hacerles a los ponentes, las pongamos en el chat. Yo voy a tomar las preguntas más importantes y las haremos. Al final vamos a tener 10 minutos para poder tener estas preguntas. Espero que disfruten mucho este evento. Al final de cada módulo va a aparecer un link en el chat. Ese link en el chat es para hacer una serie de preguntas muy sencillas que necesitamos que contesten para que nos puedan dar el aval en el Consejo Nacional de Cardiología. Es muy importante que antes de que se salgan de cada módulo, contestemos estas preguntas. Sin más preámbulos, tengo el honor de presentar a 3 ponentes el día de hoy en el módulo 1. Uno es el doctor Marcelo Hartel. Él es a cargo y director de Cardiovascular Imaging Research and Innovation Lab. Al doctor Alejandro Díaz Carrillo, que vamos a tener, es a cargo del intensivista adscrito de la terapia COVID del Hospital H+ de Querétaro. El doctor Miguel Ayala León, que es jefe de la terapia intensiva cardiovascular y coordinador del programa de ECMO en el Hospital Español de Puebla. Espero mucho que sea de agrado de todos y que tengamos información que nos ayude a todos en esta lucha contra la adversidad que estamos presentando. Sin más preámbulos, voy a dejar a cargo de la primera ponencia la importancia del diagnóstico certero en la evolución del paciente al doctor Marcelo Hartel, y muchísimas gracias, Marcelo, por estar con nosotros. Thank you very much.
Muchas gracias a todos, muchas gracias por la invitación. Es un gran placer estar acá con ustedes en SONECOM 2020 para compartir un poco de nuestro conocimiento para enfrentar con esta gran batalla que es COVID-19. Bueno, voy a hablar en inglés porque mi español no es muy bueno. When we see a patient with a respiratory complaint and we suspect of COVID-19 infection, we must know that the rapid test, which seek for antibodies in the blood, usually could have a false negative result because it delays a little bit to have positive antibodies in our body. So the most accurate test would be to seek for the virus in our arrays through the PCR test, but usually it takes some hours or days to have the results. In order to have a properly screening of these patients, it's very important to assess the pulmonary and cardiac involvement. And we need to be very careful to minimize the risk of exposure of our team and use our resources in a rational way. So do not waste personal protective equipments and avoid to contaminate the equipment. But also we need to balance this with the clinical benefit for the patient. Most of us have chest X-ray in our emergency departments, but almost 60% of these patients have normal images in the first days of infections or the first days of symptoms. And frequently, the chest X-ray will just have abnormal findings after 10 or 12 days from symptoms onset. Usually, lower zone consolidations could be found. The most accurate method for assessing pulmonary involvement would be the computer tomography. However, not all emergency departments have this. It's an expensive test, we need to transport the patient to the radiology department. It have ionization radiation and increases the contamination risk of our team and the other patients from the hospital. And moreover, it's not feasible to perform a serial evaluation of these patients. In this way, focused long and cardiovascular ultrasound has been used more and more to screening COVID-19 patients. Why? Because it has a high sensitivity in detecting pleural and parenchymal changes, as we could see from several studies comparing computed tomography with lung ultrasound in pulmonary congestion, pneumonia, and critical care patients. It is a ionization radiation-free exam. Could be performed at the bedside. It's very feasible and reliable, and with a low learning curve. And it's very useful for evaluation and monitoring the cardiovascular and pulmonary systems in these patients, so we can perform serial assessments. And the most important thing is that lung ultrasound have a high negative predicted value. So when we are screening a possibility COVID-19 patient, if lung ultrasound is negative, is normal, the localize of this patient to have COVID could be very, very low. In this situation, ESCVI and American Society of Echo performed two very important recommendations papers to the use of cardiovascular imaging and focused ultrasound for screening and evaluation COVID-19 patients. And when you look these tests, we will see that the focused cardiac and lung ultrasound is highly recommended. And must be the frontline examination before a comprehensive echocardiographic study. So we can assess the right patient to perform a comprehensive examination and seek for the patients that you could solve and perform a good assessment just with focused information. And this same recommendation is provided by the American Society of Echo. And we could see that the patients with high suspicions or confirmed COVID-19 infection, the first line exam would be a focused imaging evaluation. But when we perform a focused ultrasound in COVID-19, we need to know that we need to state a very, very precise question to be answered. So we will just perform examinations in concrete clinical situations in which this imaging modality would provide clinical information to change the medical conduct in this patient. Another very important thing to be stated is that sparse literature about ultrasound in COVID-19 patients is found nowadays. Lot of research are being publishing in the last months, but most of the information we use for these patients is derived from other studies and other type of patients, not from COVID-19. So in this lecture, we will focus on lung ultrasound, how to do and how to identify the main sonographic findings, and focused cardiovascular ultrasound, how to identify the main sonographic findings. About lung ultrasound, from a longer period of time, we thought that lung ultrasound would not be feasible as examination because ultrasound imaging needs a dense tissue to form the images, and the lung is contained by air. So the lung, the ultrasound energy would be dispersed and no imaging would be formed. And this is quite true, because when we place the probe in thoracic wall, most of the lung ultrasound energy is dispersed, and the imaging we have in the screen is not properly imaging, is artifacts. But when we started to look these artifacts and seeing the different patterns, it started in 1960s, the first reports, and 1980s, the first researches. We start to realize that the change of these artifacts could be related with some lung injuries and lung disease. So, performing the lung ultrasound, we need to understand the basal imaging, the normal imaging. When we place the probe in thoracic wall, we will be able to see the soft tissue, the skin, the muscle, the ribs, and the pleural, the parenchymal pleural. But all the images below that would be artifacts. And that is the imaging we saw in a normal lung. Let's understand this image. So, the more proximal imaging is the soft tissues, and all image above is artifacts. In this soft tissue, you can see muscles, the skins, and the ribs, and you can see the shadow, the acoustic shadow of the ribs on the artifact zone. Between the ribs and right above this soft tissue, we can see a very dense echogenic line. This is the pleural line, made by the parenchymal and the wall pleura. And above, we will see several parallel lines that we named A line. This artifact is the repetition of the pleural line by the ultrasound machine. So here we need to fix this image. This is the image of a normal lung. As we can see, we have the pleural line. We can observe the lung sliding, this pleura is sliding, and the A lines. But when the parenchyma of the lung starts to change with a comment, we could start to see that energy of ultrasound does not works in the same way of a normal lung. In a patient with extravascular lung water, the energy of ultrasound starts to reverberate between the thickened interlobular and interalveolar septums, and a different artifact starts to appear. From the pleural line, we can realize some lines that go in vertical way that moves with the lung. And this line was named the B lines. If we consider a normal lung, we have the A lines. A lung with a mild pulmonary congestion, we start to have some number of B lines that increase with moderate and severe degrees of pulmonary congestion. So it is a way also to semi-quantitative assess the degree, the amount of extravascular lung water. The normal lung is black on our skin. The lung with a mild degree of extravascular lung water appears as a gray and white. With an pulmonary edema, we can see a white lung. And a lung with consolidations, we can see a gray image and an image like hepatization, like the liver. Here, we can see the different imaging obtained in a patient with alveolar syndrome, interstitial alveolar syndrome. We can realize the B lines formating from the pleural line going to the down of the image and moving according to the respiration. And another important image that we need to fix in our mind is the lung consolidation. So we can see properly the parenchyma of the lung because it have almost no air inside. We can realize the texture, the echogenicity is quite similar to the liver. So that's why we name it the hepatization. And we can say these bright areas that are collapsed air inside the bronchus. This is the sonographic bronchogram. To do the lung ultrasound, what we need? We need basic technology. So we need, you could use even the old ultrasound machine that the radiology do not want anymore to use. So you just need a bidimensional imaging. We do not need Doppler, and it's not necessary harmonic imaging. And what type of equipment? We can do a lung ultrasound with all the types of equipment, but it's widely recommended to use portable ones or the pocket size ultrasounds because they are more portable. It's easy to go to the bedside of the patient and quite easy to perform the infections. And what probe we should use? We can use the linear probe to assess the soft tissue and the pleura. It's quite good to visualize the pleura and the pleural commitment, the pleural thickness, subpleural consolidations, and also to diagnose pneumothorax. We have a high proximal resolution, but we cannot see far away images. And then we can use a broadband phased array probe, the same we use for echocardiographic examination. We can realize more the lung area, or we can use even the broadband curved array. And what time of preset we should select in our machine? We should select lung, or if not available, abdominal preset. The game we need to optimize to see the pleural line. Too much gain is difficult to assess the B lines, the A lines, and the subpleural consolidations, and too low gain we will not able to see any image. And how deep we should imagine? Around 8 to 10 centimeters. And our methodology, where we should scan. We divide both hemithorax in 8 regions. Anterior, axillary anterior, axillary posterior, and posterior regions. Cranial, above the 4th intercostal space, and the below images under the 4th intercostal space. And what we should look for in COVID-19 patients. The first thing we need to keep in our mind is that pleural effusion is quite hard in these patients. So usually when we find it, it rule out the possibility of COVID-19 infection. We should think more in cardiogenic dyspnea, heart failure, or even a pneumonia. In COVID-19, it's very frequently to find pleural thickening or irregular pleura, B-lines in a quartine way or in a spread areas, subpleural consolidations, and in progressive disease, in advanced stages, large consolidations, when you have superimposed bacterial infections. Here in the first images, we can realize up left thickened pleural line with a subpleural consolidation and B-lines in quartine. And below imaging on the right side, we can see normal pleural line and B-lines in spreaded area. It is very important because in COVID-19, we can find normal lung and spread areas of compromised lung. And here, with the linear probe, we can realize much better this subpleural consolidation that seems like a leak in pleural line. So, in early stages, when we start to have a small amount of spread areas of ground glass on computed tomography, we imaging in ultrasound these spread areas of B-lines. In intermediate stages, when the areas of ground glass takes more part of lung parenchyma, and we have thickness of interlobular, interalveolar, and pleura, we start to see a irregular pleura along ultrasound and some images of subpleural consolidations. And the B-lines start to be in quartine instead of spreaded areas. And here in severe stages, we start to have pulmonary consolidations on computed tomography, and also in lung ultrasound, we start to see these subpleural consolidations more and more frequently and with a great sizes. And the extreme stage, very advanced disease, when we have superimposed bacterial infections, we could have these huge consolidations, and we could realize these bright areas of collapsed air moving according to the respiration. So this is the ultrasonic bronchograms. Here we can compare these findings. On the left, we see a normal lung with a normal pleural line with a lung sliding and A-lines. On the middle image, we see some B-lines, spreaded B-lines, and the pleural line started to be irregular. And on the right image, we see a thickened pleural line with subpleural consolidations and B-lines in quartine. And here we have a great subpleural consolidation on left with B-lines and thickened irregular pleura. And on right, we can see a very, very small pleural effusion. So how we could compare these findings between examinations when we are performing a monitorization, a lung ultrasound monitorization in your patients. So we could use a strategy to create a score of findings like we use it in other critical care patients. So we will give a score of 1 if you find at least 3 B-lines or convalescent B-lines taking less than 50% of the screen. And if you find a subpleural involvement, we add the letter P. So it would be score 1P. Score 2 would be when we have convalescent B-lines taking more than 50% of the screen. And as we said before, if you have subpleural involvement, we will add also the letter P. And score 3 is when we have consolidations, and it's very important to describe the characteristics of these consolidations, and if you have bronchograms, the location of these consolidations, the size, and the pleural effusion. So from that 8 sides from 8 points evaluated from each hemithorax, we state the score from each one and sum these scores to have the total score of the patients. In this example, the patients having some points score 1, in others 3, in others 2, and the total amount would be 17. And we need also to describe the number of areas with subpleural involvement, the areas that we added the letter P. In this patient would be 3. And also a qualitative description is very important. And recent research has demonstrated that we can have 2 different phenotypes of these patients, of 2 different lung accommitments. And we have patients with type L, that is the patients with low elastance, the patients with a good compliance. These patients have low ventilation to perfusion rate, low lung weight, and low recruitability. These patients used to have a good evolution. And the type H, the high elastance patients, they have a high right to left shunt, high lung weight, and high recruitability. In these patients, the lung ultrasound will find subpleural consolidations and B-lines in cortines, in comparison to the low elastance patients that you can see just a small amount of spread areas of B-lines. In our institution, we are using a protocol like this. So every day, when we perform an evaluation of the patients in critical care, we scan the lung and note the findings from each of these regions of the thorax in order to monitor if the patient is deteriorating or getting better. And also we have some items from cardiovascular focused ultrasound. About the focused cardiovascular ultrasound, when we should do it, we need to know that about 1/4 of the critical ill patients will have myocardial injury. And it would be very important if you could do a focused evaluation right after the lung ultrasound. Why? For screening for subsequent exams, to know if we need a comprehensive echocardiogram, to detect a pre-existing myocardial involvement, early identification of worsening of myocardial function, monitoring the myocardial function, and also elucidation of cardiovascular abnormalities potentially related to COVID-19. So we should also assess with focused cardiovascular ultrasound the patient in shock to realize if he have a pericardial effusion or myocarditis, a patient with hypercoagulability state, and also to assess the systolic dysfunction. From a global evaluation of echocardiography in patients with COVID-19, we have this data published a few weeks ago. We realized that about 48% of COVID-19 patients have some cardiac abnormality found on echo. And it's quite interesting because they created this graphic to demonstrate the relation between the indication findings and impact. And if we look this image, less than 1/3 of these patients, the finding on echocardiography change the medical conduct and have an impact on evaluation of these patients. And you need to know that severe findings is in less than 25% of these patients. Which images we should take in a focused cardiovascular ultrasound examination? First of all, we need to start with a subcostal evaluation to have a global evaluation of right and left chambers, and also to evaluate the size of vena cavae to know the hemodynamic status of these patients. Then we should move for a long axis view to evaluate left ventricular function and size, and mitral and aortic valves. Then a short axis to assess LV systolic function, and a four-chamber view to assess not just the left ventricle function, but also the right ventricle size and function. According to American Society of Echo recommendation on focus on COVID-19 patients, from cardiac evaluation, we should assess the size, global and regional function of left ventricle, paying attention to myocarditis, acute coronary syndromes, cardiomyopathies, and shock. From the right ventricle, we need to assess the size and function, and if possible and available, assess the pulmonary systolic pressure, and paying attention for pericardial effusion and cardiomyopathies. Pulmonary embolism, sorry. And about the pericardium, so assess the effusion, and if you have tamponade, and valves, a gross evaluation to assess regurgitation or stenosis as a pre-existing cardiovascular disease. Here we have an example of a COVID-19 patient with severe left ventricle systolic dysfunction. We could realize asynectic apical regions. And on the right imaging, a subcostal view of the same patient. We could see a normal right ventricle, but a severe dysfunctional left ventricle. This is another patient with a different finding. He has a hypersynetic apex, but asynetic basal, mid-basal segments. Thinking that like inverse stress cardiomyopathy, Takotsubo. When we started, I don't know what happened here. Just a minute. I think closed my presentation. Sorry for this trouble. Okay, here we go again. From the beginning of the COVID pandemic and outbreaks, we have a report of several cases of stress cardiomyopathy, Takotsubo. But this recently research published on JAMA Open Network showed us that the number of patients diagnosed with Takotsubo rised more than double from the previous period. But it's interesting that almost all of these patients, there was a negative COVID-19 test. So they suggested that this economical, psychological, and social impact of the pandemic could be related to the presence of Takotsubo in more prevalence nowadays in our population. Here we have other examples. A patient with myocarditis on left with a severe left ventricular dysfunction, and on right, patient with pulmonary embolism and a rectified interventricular septum. Other thing very important to look in our Fox examination, I will not go in advanced and comprehensive echo because it's the next lecture. We need to look the right ventricle. So it's very important to assess the size and the function, because some studies related the right ventricular dysfunction with a worst outcome of the COVID-19 patients. And also need to look the veins, because these patients have a high thrombolytic state, so we can find thrombus in inferior vena cava or other deep veins. And to finish, I will show this case to illustrate. A man of 60 years old with previous arterial hypertension and dyslipidemia. He seeked the emergency for dyspnea. He was with 8 days of fever, cough, mild abdominal pain, and diarrhea, and was using azithromycin on the previous 3 days. No fever at admission. Saturation 87%. Okay, and the heart rate of 96 beats per minute. Here we can find the X-ray. We can see this compromise of both lower lobes. We performed a lung ultrasound. We find the B lines in Cortin and a subpleural consolidation, some areas of irregular pleura, and some areas of normal pleura. And the ECG showed these dynamic changes on precordial derivations and suggesting a myocardial infarction. This patient was evaluated with enzymes, serological tests, and also catheterism that was normal. And we can find here increased value of troponin, D-dimers, prolactin, lactate, and also creatine kinase and BNP. The Fox ultrasound demonstrated this left ventricle with severe dysfunction. This is the same image that I showed the previous. So we have this mid-apical compromised zones. During the evaluation, these patients evaluated with a right bundle branch blockage. And we have here the curve of the enzymes, so the troponin of these patients, the ferritin, creatine kinase. Also the prolactin, the dimers, and the liver function. So this patient was diagnosed with myocarditis. And during the evaluation, he recovered completely the myocardial function. So just to finish, this is the protocol you use in our patients when we assess a Foxed lung and cardiovascular ultrasound. We have these images just to remember us what to look for, and then we complete the fields, the lung fields with the findings, and we also note what finds from the cardiovascular Foxed ultrasound. As a final message, Foxed lung ultrasound, we need more evidence, but we know from the research and from our clinical practice that is one of the most useful tool for evaluation of these patients, because it's much more sensitive than chest ultrasound. Is very useful for screening and monitoring not just mild cases but severe patients as well. he has a high negative predictive value. He's used also for risk stratification and prognosis from the patients. We could see changes in lung very early before clinical deterioration, and is useful for monitoring clinical response to drug treatment, ventilation support, and the moment of weaning from mechanical ventilation. And focused cardiovascular ultrasound, we should look for the LV systolic function, RV overload and dysfunction, and pericardial effusion. And if possible, combine both focused cardiovascular and lung ultrasound in our evaluation. So keep safe and protect ourselves, and we should be strong to face this battle with COVID. Thank you very much.